Welcome to this presentation of new interRAI research published as part of the Frontiers in Psychiatry special issue on innovations in the mental health applications of interRAI assessments. My name is Keir Johnson. I'm from Doctors Manitoba, and I'll be your moderator for today's session. Today's presentation will include 3 interRAI fellows who collaborated on a paper called Costs and Savings Associated with the Police Use of the interRAI Brief Mental Health Screener. We'll begin with a brief presentation by Dr. Ron Hoffman. He's an assistant professor in the School of Criminology and Criminal Justice at Nipissing University. He devoted many years of his career to police training at the Ontario Police College, and prior to this, he held employment as a police officer, probation and parole officer, and community college teacher. He'll be joined by Dr. Jeff Harman, a professor at Florida State University. Jeff is a health economist with expertise in mental health services research. Also on the panel today is Dr. Greg Brown, professor at Nipissing University. Greg is a sociologist with expertise in corrections and criminal justice research. At the end of the presentation today, we'll provide a web link to the articles in the special issue. Ron, over to you.
Thank you. So my presentation is on the costs and savings associated with the police use of the interRAI Brief Mental Health Screener. What the screener is the 23-item evidence-informed screener that was developed primarily for police to be able to identify indicators of serious mental health problems. Now, there have been different attempts made to enhance the police response to people experiencing mental health issues. For example, CIT, Crisis Intervention Training, or co-response teams, CRT, and hub situation tables. A lot of these, there has been some evaluation done on these different response modes, models, but overall not as much as there should be, and almost none has been done on the cost effectiveness of these models. So what we wanted to do was to look at the cost effectiveness of the interRAI Brief Mental Health Screener, the BMHS, as an alternative model that police could use to help enhance the response to people with mental health problems. The setting was a mid-sized city in southwestern Ontario, fairly representative of cities in Canada and Ontario. The data was primarily from the assessments that were completed by police officers over a 3-year period from 2018 to 2020, and there were approximately, or just over, 6,700 assessments completed. We looked at the rate of ED versus no ED referrals. So this is the number of times that police officers would transport somebody to the emergency department versus not. And over the study period, we can see almost a 30% decrease in ED referrals versus an increase of almost 50% in no ED referrals. And part of that could be due to the police officers just becoming more familiar with the screener, and they were instructed to fill it out on everybody they encountered, versus in the past, they may not have even interacted with the person because they really don't have lawful authority unless there is a serious issue. Involuntary versus voluntary referrals, we see a decrease in both. Average times, we see a decrease in the times overall, and we see a decrease in the wait times that police officers, that's the time that police officers would remain in the emergency department. So all of which resulted in significant cost savings over the study period. Now, what could have caused the increase in mental health referrals or contacts could be just the officers, as I said, becoming more familiar with mental health calls. It could be because in the past, they may not have even interacted with somebody if they hadn't, and they were trained to fill out the form on everybody this time. The decrease in involuntary referrals could be due to the police having a more informed understanding, or it could be because of the introduction of the co-response team, which we were unaware of at the time, but this department started to use this alternative model, so they may have been the reason why the referrals there was a decrease in referrals. Determining mission status, which was not included, may have provided additional information for specificity. The biggest problem we had was that and this is typical of police services, they do not collect a lot of non-crime related data, and we didn't have pre-implementation data. And of course, the costs were determined based solely on police officer salary, so as opposed to real costs. So in the future, it would be interesting to determine real costs of policing and use that just as opposed to just wages alone. So overall, benefits of BMHS, its use did result in significant cost savings, and so it's a viable alternative option for police services. Thank you.
Thank you very much for that presentation, Ron. Very, very interesting. I have a few questions for you, and then I'd like to bring in a few other members from the panel. So Ron, for you, as a former police officer, you obviously have some unique insights here. And maybe to start, why are police officers often the first point of contact for persons with mental illness? What training do they normally get to prepare them for this role?
This is a very interesting question, and one that's been asked for many years now. It's safe to say that since the period of psychiatric deinstitutionalization in the mid to latter part of the last century, police officers have assumed an increasingly active role in responding to mental health calls for service. Why? Many people point to the lack of adequate community-based resources. The move to a community-based treatment did not occur exactly as planned, and many of these services did not materialize. There still are gaps in services. People talk of the lack of collaboration between the systems and services that currently exists. Mental health legislation in itself is it made it increasingly difficult to institutionalize people against their will. And the reality is that if there is a danger to public safety or a risk to public safety, there is only one service to call, and that is the police service. And unfortunately, this has led to many documented cases with tragic consequences. What type of training? Again, very controversial. Hotly debated subject and difficult to answer. Why? Because training standards differ across the country and differ across nations. It's safe to say that most basic training for police includes some component on mental health, and most in-service contains some elements of training on mental health. But it is safe to say that the consensus is that police officers do not receive the level of training that is required.
And maybe just a practical question for people watching. How is the brief mental health screener actually used by a police officer when in contact with a person with mental health needs? And maybe just as a secondary part of that, could you tell us how that ultimately leads to a drop in involuntary referrals that you observed?
Okay, so the brief mental health screener, it's a short screener. There are only 23 core items. The software, of course, it's not a paper form. It's used through software that's on a cell phone that the police officers use, and they are instructed, they are trained to complete the screener on anyone they encounter who they believe may have a mental health problem. And this information is stored in the police database, but it also can be sent electronically to a local mental health emergency room, hospital emergency room, or it can be sent to local mental health community service providers. Now, so when it's sent to the hospital, it can be a early warning system for the hospitals that they know that the police are bringing somebody in. with a mental health problem. And with the community agencies, it could be a situation where officers have observed the earlier stages of a more serious problem, and they're trying to connect that person to required services. What the screener does, police officers have always had the ability to record their observations. In fact, they need to do that to be able to provide that evidence to emergency room physicians to assess the severity of the disorder. But what the screener does, especially, particularly with the risk scores, there are 3 scales that are computed on danger to self, danger to others, and inability to care for self, which are plotted according to the date of which there was an encounter. When the scores reach a certain level of severity, it will help inform the officer as to when to take that person to the emergency room. So it supports their decision making in that situation.
Thanks very much for that, Ron. I'm going to try and bring in the next person on our panel, maybe to focus on some of the economics here. And that's, of course, Dr. Jeff Harman from Florida State University. Jeff, you'll probably be a little biased as a health economist, but I'm wondering if you can help me understand why it's important to do economic analyses of interventions like this when we're considering mental health challenges in society more broadly.
Sure. So, as we've learned over time, is that there are a lot of effective interventions out there, mental health interventions out there, that really aren't widely implemented or widely used. And when we try and figure out, so why is it that these interventions that we know work aren't really being used, is one of the most commonly cited reasons is lack of resources, or the costs of implementation, or the perceived costs of implementation. So, when you conduct an economic analysis that really carefully considers these costs and the perceived benefits of this information, is it can help demonstrate the return on investment of implementing something like that. And so knowing this information can really help decision makers, make an informed choice about whether they want to implement or not implement an intervention. And often what they'll find is, like, they'll say, oh, this is too expensive, this intervention, but, they're not really considering all of the effects of that intervention. So it actually, even though it may cost money up front in the short run, in the long run, it could actually save your organization money and make it more effective.
So it provides a kind of a more holistic view from an economic perspective.
Right. Yeah. People often don't really consider all of the sort of the costs and benefits associated with it. So this really helps people get the full information so they can make informed choices.
That makes a lot of sense to me. And so what are the key questions you're interested in as a health economist when you're evaluating a mental health service?
So, you want to know what the costs that are associated with providing the service. So that's going to be the cost of all the inputs that go into producing that service. But also, you want to know how many people are going to use that service and receive that service. And also, trying to understand the downstream effects that service may have, on the individual, on the healthcare organization or society, depending on what perspective you want to take. How you measure those costs and benefits is going to basically it's going to be determined on what perspective you're taking. So like in this study, we were taking the perspective of the police departments. So what are the costs and benefits associated with them? So while sometimes, it makes sense to focus on the benefits and the cost to an individual, sometimes it's, the organization, sometimes it's for the people paying for the service, right? So it'll, how you measure it and how you present it will depend on sort of what perspective you want to take and sort of what decision makers you're targeting for the study. Because, ultimately you're trying to measure these things to help decision makers, make informed choices. So, if you're trying to get an organization to adopt an intervention, then you want to measure the costs and benefits that specifically apply to that organization.
That makes a lot of sense. And I imagine that as you're thinking about this more broadly and holistically, there's some non-monetary costs and benefits that factors into your analysis. Could you give us a couple of examples of what those might be in this context?
Yeah. So there's a lot of things where, often when we do a cost analysis, there's, you pay a specific dollar amount for something, right? And that's easy to measure. But then there's a lot of things that aren't necessarily measurable. So like in this, in our study, for this study, the officer time in the waiting room. We don't really think about that as a cost, but that actually is a cost. But measuring these kind of non-monetary costs is always tricky. What you're trying to do is assign a value to costs and benefits so that you can kind of make an apples to apples comparison of, is this, you want to use this intervention or this intervention, or put these resources or these resources. And so to do this, you do things like measure opportunity costs. In this study, we think about, officers are sitting there in the waiting room at the emergency department. Well, what are the costs associated with doing that? So those officers could be using those resources, spending their time doing other things for their communities, protecting and serving their communities. And so, so we do things like trying to measure opportunity costs. And that's, this idea of, what are the costs of forgoing an activity to do a different activity instead. Maybe it's something that there isn't a cost associated with it, but you could be using that time to do something else where there is something that would be easy to measure in terms of dollar amounts or something like that. But sometimes we might want to conduct a survey to establish like willingness to pay or time trade-offs to measure these kind of things. That might be if we're looking at individuals, how much they would be, their preferences for different individual health states. Not necessarily applicable to this particular study, but like one thing that we often do is say, how much time would you trade off in a compromised health state? So 10 years, where you're not at full health, how many years of perfect health would you be willing to trade off for that? So, maybe you'd say, I'd take 4 years of perfect health as opposed to 10 years in this compromised health state. So, economists, we've sort of developed several different ways of trying to assign costs to things that don't traditionally have like a dollar amount associated with it.
Okay, thanks so much for that. I'd like to bring in the final member of our panel now, if we could, Dr. Greg Brown, professor and sociologist from Nipissing University. Of course, interRAI has been engaged in several studies related to criminal justice, including forensic psychiatry and corrections. And I wonder if you could help put this brief mental health screener into context for us as it relates to the broader picture of interRAI research in this area.
Yeah, there's about 5 instruments so far that we've used in the criminal justice area. Of course, the brief mental health screener, which is now being used in police services across Canada, and now also being used in the United States. We have a forensic mental health screener. We have a mental health assessment that was used in Michigan state prisons in the United States. We recently completed a study of healthcare needs of older offenders, a national study here in Canada with Correctional Service of Canada. So really it reflects a response to a need being expressed to us from the field that, as Ron mentioned, the police are often the frontline gatekeepers in dealing with persons in crisis, whether that's a mental health crisis, whether that's related to addictions, etc. And what we're doing in interRAI is increasingly trying to respond to those needs being expressed by different parts of the field. Can you help us with assessment and appropriate referral of individuals so that they get the help that they need? And if that help doesn't involve the criminal justice system, then they should be referred to other services that are much more appropriate to address those needs. As a result of the use of the interRAI BMHS, a number of police services, including the Ontario Provincial Police, have recently launched additional initiatives to, once the referral is made, having people work in the comm centers, doing calls, following up police officers' assessment to make sure individuals get the help they need. So it's really been a catalyst, the interRAI BMHS, for getting the police and the community together in dealing with not just mental health, but addictions needs and other types of needs, individuals who are struggling, who are homeless, unable to care for self. So it really has been a catalyst for that, the interRAI BMHS.
Well, thanks for that, Greg. And just for all of you watching, BMHS, of course, is the Brief Mental Health Screener. And if you're new to interRAI, you'll develop a love for acronyms very quickly. One last question for you, Greg. From a human rights perspective, how can these interRAI tools, the interRAI systems, improve the lives of people with mental health concerns who come in contact with the justice system? And you alluded to that in your last answer, but I'd like to delve a little deeper into that.
Well, as the paper shows, in the past, the traditional response in policing was you either arrest the person or you take them to the hospital. And what the interRAI BMHS provides policing is an alternative to that old style, where the officer can assess and make appropriate referrals to community agencies without criminalizing this individual by arresting them, and without medicalizing them by taking them to the emergency room where there may not be a need for that. And so the success of the interRAI BMHS has been in recognizing that there are lots of alternatives available to the police. They just need an instrument that supports them making those referrals and contacting the appropriate agencies. The other thing that's coming out of the interRAI BMHS is interest, for example, by paramedics and other frontline agencies in adapting the tool for their use as well. And ultimately, the goal is people in crisis, whatever that crisis is, if the police are the first point of contact, it's ensuring that those individuals get the help they need. And that's really what the tool is about. And if that tool doesn't involve the police, then the police involvement should stop at that point. Or if that help does not involve the police should stop at that point. The individual gets referred to appropriate agencies.
I have one last question for the panel before we wrap up. And I'd say that overall, this sounds extremely encouraging. I can't imagine why a police service wouldn't adopt this tool. It's a very compelling case. Involuntary referrals are down. I think I saw in Ron's presentation that there were also an increase of maybe referrals for other health services, other mental health supports that increased. So overall, it looks like people are getting off what some might call the wrong track and onto what others might call the right track. I'm curious if there's any downsides. I could see some people being worried that a brief screener like this might miss somebody who should be put on a track towards an involuntary or voluntary referral because they're in need of some urgent help. And is this something that was picked up in the research at all? Or are there any other potential complexities that people should be aware of when adopting something like this? And why don't we start with you, Ron, and then we can go to Jeff and Greg.
Thanks, Kira. I think it's important to remember that the police are going to continue to do what they've always been doing. And if they see somebody or encounter somebody who they believe has a serious mental health problem, they're going to take them to the hospital. The BMHS supports their decision to do that. It doesn't replace. They're still going to take serious people along. Using the BMHS, though, it increases the number of people that they would encounter with mental health problems. Some often in the past, if they had minor problems or they weren't a serious threat to life or property, the police wouldn't get involved at all. So if anything, it's expanding the number of interactions police have with people with mental health problems, and possibly catching them at an earlier stage than they would. So we're using police in a different way now with the use of the BMHS.
Jeff, anything to add to that? Or?
I don't really see a lot of downsides to implementing it. I mean, there is the possibility that, as Ron pointed out, that you might identify more people in need of mental health services, and that may cost your municipality more money, but that's money well spent. So I honestly don't see a lot of downside with it. It's possible that, police officers may be like, doing one more assessment or something like that is taking time away from the community. But I think we're demonstrating through our research that, there really is a positive impact of implementing the BMHS.
And maybe over to Greg for the last word.
Well, and again, I think the interRAI BMHS, as Ron has mentioned before, police officers were always in the position of wanting individuals to get the best care that they could. And what the interRAI BMHS does is support that with data saying, yes, this is a person who's in need of help, and we need to provide something for them. And if the appropriate referral is to a community agency, that's great. So it basically is just supporting what officers always did, but doing it in a better way.
Well, I'd like to thank all of you, Ron, Jeff, and Greg, for your work on this very important research, interesting topic. We look forward to following future developments in this important work. And to everybody watching, I'd like to thank you for joining us. This presentation on interRAI's research into mental health and addictions is part of a series. If you'd like to learn more about this and related work, you can always contact us at info@interRAI.org. That's info@interRAI.org. Thank you very much.
To see all the articles in this special issue of Frontiers of Psychiatry, please visit the website shown here, or click on the link posted below this video. Visit the interRAI website at www.interRAI.org at any time to view the new presentations on this special issue as they are posted.